Hi everyone, today we're talking to Anna Stevens, who's an actuary working at New South Wales Health. Anna and her team use advanced analytics to design, monitor and evaluate new models of healthcare being piloted across the state. She's worked across Australia, New Zealand and the Netherlands using her technical skills and health knowledge to help governments improve patient outcomes. Anna, thank you so much for joining us.
Thank you for having me, Julia.
So Anna, you use analytical techniques to help governments make decisions about how to sort of improve the chances of patients having access to the right care in the right place at the right time. Tell us a bit about how you got to be in this position. That sounds like a really, really interesting role.
It's a fantastic role. It's very rewarding. So I guess the way that I got into government is that I was working as a consultant for a long time, and I was working closely. One of my clients was the collaborative commissioning team at New South Wales Health. And so just for a bit of background, the collaborative commissioning team was established by New South Wales Health as one of their 4 strategic initiatives to enable the transition to value-based care. And so their role was to support regions across New South Wales to kind of redesign models of care and to support the primary networks, the primary health networks and the local health districts to come together and say, how can we improve the patient journey? And so breaking down those barriers, if you like, required some sophisticated analytics in order to evaluate the financial sustainability of these different types of models. So at the time I was working as a consultant and supporting collaborative commissioning, but I was really ready for that next challenge within my career. And I just thought this team has everything that I'm looking for in terms of the type of work, in terms of the team environment. And so when I heard that they were thinking about bringing the analytics in-house and they'd started advertising roles within their team, I just thought it was an absolute no-brainer.
What a great opportunity.
Yeah, it really was.
So Anna, you said you used the term value-based care. Can you explain what that means?
Yeah, so value-based care is essentially focused on the quadruple aim. So it's thinking about how we can design care to support value to our community. So thinking about the patient experience, the provider experience, the quality of the care that we deliver, and also its long-term sustainability or longevity. So it's really a move away from care where we pay for volume or activity towards one that just improves the overall value.
Right. So a more holistic sort of view of what's being delivered and not just looking at what's being done, but what the outcomes are.
Yeah, exactly. So, not just incentivizing surgeons to send someone for a knee arthroscopy because they get paid a lot of money, but thinking about how could we support that patient to have better rehab to kind of prevent the need for that operation in the first place.
So, I mean, lots of actuaries work in private health insurance, but, this public health actuarial role is quite different, isn't it? So, and you've done work for public health as an actuary in this current role, but also as a consultant beforehand. So I'm wondering, Anna, can you tell us a bit about sort of the value that you think actuaries bring to the public health setting?
Yeah, absolutely. And I think it's a really exciting space to be in because I do think that the actuarial role is up for definition. It's currently undefined, but there's so many areas I think that actuaries can play a part in public health. If I had to break it into 2 categories, I think that there's a role that can be played at the system level, kind of at a higher level view, and then at a program level. So I guess in terms of that system level, the way that I see it, and this is just my view, is that actuaries can play a role in kind of setting and monitoring the budget for health services and ensuring that that's distributed equitably across the regions. So I think as part of this process, there's a role for actuarial style models that take into account those changing demographics, population health, and models of care and how they look now and how we expect them to look heading into the future. One example is the uptake of telehealth that we've seen during COVID. How do we factor that into our budget setting going forward into the future? I think at a program level, the public health departments are also really focused on how they should prioritise their investment into new models of care that allow us to continue to deliver high quality service that provides those good patient and provider experiences. And so this is what I mentioned earlier around this transition to value-based care. I really feel as if that investment in new value-based healthcare initiatives is an excellent application of the actuarial control cycle because it requires both strategic and analytical input into the design, into the implementation, and into the monitoring in order to estimate and evaluate the long-term financial benefits and costs and risks and inform those investment decisions. And it's such an open and new space. And so just to give you some practical examples of the kind of models of care that we're looking at, some of the regions we work with in collaborative commissioning, they're designing better models of care for the frail and elderly to stop them coming into the emergency department with things that could be managed through the support of a GP or a practice nurse. And, you know, often with these old patients, if they come into the emergency department, they might have a secondary infection or a fall that might lead them to stay for a longer period of time and could, you know, if there's dementia involved, could lead to further deterioration. But when we're designing these models of care, often the things that we're thinking about is how are you defining your cohort? I guess with the frail and elderly, it's maybe a little bit more obvious, but if it's diagnosis related, how well is that diagnosis captured within the data? And what other indicators could you think about if you feel like it's being underreported? Some of the other things we think about is how do the costs of delivering these services differ in different settings? So how much does it cost to provide this care in a primary or community setting versus in an acute care setting? And how does that differ across a metro region versus a rural or regional setting? And being really cognizant of that and making sure that we reflect that when we have conversations around what is sustainable. And then the last thing, I guess, that we also think about is how do we estimate the benefits of avoiding some of these potentially preventable acute episodes? And where exactly do these benefits flow to within the system? You know, in Australia, we have a very complex health system with federal and state funding. And so who is the beneficiary of these new models of care?
It's really, really interesting, Anna, isn't it? Because, you know, with health insurance, the user's paying, as the consumer is paying a premium and then getting benefits. But the public health system, you know, it's sort of funded, like you said, it's quite complex, and we tap our Medicare cards to do things, or we go to the hospital for free. But is emergency the most, it's quite an expensive way of getting healthcare, but what if there aren't any other options, or what if they're more affordable or the cheaper options are not available in different areas? So very interesting challenges.
Very, very difficult challenges. You're right. And it's often related to kind of access to other health services.
And I'm really interested in what you were saying, Anna, about equity, you know, making sure you've got fairness and an equitable allocation of funding and services across the state, because like you said, with regional and remote areas, it can be very difficult for people to access services too. So how do we ensure that all citizens have sort of the same fairness and the same access to services that they need?
Yeah, and that's often something that we come across when we're working with these regions, is that, you know, the metro areas often tend to have better access to workforce to deliver their services. So they can often get that at a discount in comparison to what it might cost to deliver those services in a remote area. And similarly, the infrastructure that they have access to. So I think there's been a regional minister that's been appointed to oversee that kind of equity issue. So it'll be really interesting to watch that space.
So it sounds like there's actually lots of areas that actuaries can use their skills to help in public health, whether it's, you know, looking at equity or fair allocation of resources. That you talked about funding. So even though we don't think of public health as something that we pay for, even though as a population we pay for it, there's still, you know, budgetary allocation and monitoring type decisions that need to be made at a system level. And you also talked about some program level work that we can do as well. So what would you say, what advice would you give for to other actuaries who are also wanting to make a similar move and use their skills in public health?
I think, we would welcome them, first of all. Absolutely. Very, very happy to see more actuaries in the public health space. I think the biggest barrier to entry, or the biggest thing to wrap your head around, is just the complexity of public health, as you were alluding to, Julia. So there are many government and non-government stakeholders. So you have the state departments, you have the federal departments, you have the insurers, you have the private and public hospitals. And along with that, there's lots of context-specific terminology or abbreviations that get thrown around. So in order to wrap your head around all of those moving parts and apply the actuarial skill set to best effect, I think it's really critical to invest some time in building that domain knowledge, understanding what are the different care settings, primary care, secondary care, tertiary care, and thinking about what are the sources and manner of funding for these parties and how that might incentivize certain behaviours. So thinking, particularly depending on whether they're paying, whether providers are being paid for outcomes or whether they're being paid for activity, that can certainly drive different types of behaviours.
And so much terminology there. I mean, how it's like a whole nother language. And so you talked about, the benefit of investing in building that domain knowledge and understanding that terminology. What are some practical ways that people can do that?
Yeah, so I think probably a combination of things. So I think you can tackle this, informally, if you like. So putting your hand up to work on projects in the public health space, you'll get that transfer of knowledge from the client or from your other colleagues, or doing your own kind of desktop research. So, reading some articles or understanding the key players within the industry. That's certainly how I acquired my knowledge. And then I have colleagues that have also gone the more formal path, which I think is really valuable. So doing a master's in public health. And I think that gives you a really good, broad understanding of the industry.
So some informal options and just, understanding the industry and reading widely and talking to people, but also there's some formal options if you're wanting to go down that path as well.
Absolutely.
Yeah, interesting. So, so finally, Anna, what else do you think? Is there anything else that you'd like to share that you think people need to know about the value of actuaries working in public health?
Only to say that I do really think, from my biased point of view, that actuaries are really well equipped to use their skill set to consider some of the longer term consequences and risks of certain policy decisions that can really shape the direction of healthcare funding and delivery. And I think, my observation working in public health is that sometimes you can see outcomes or investments get tied to a particular party or a particular election cycle. And so being able to shift the dialogue or shift the conversation by providing insights from data or building models to demonstrate the benefits of those longer term investment strategies, as well as, having an open and honest conversation about the risks and how they're shared across the different parties. I think that's a really valuable application of the actuarial skill set, and something I think that we're seeing across broader government in general. I know as well in the child protection space that's increasingly popular. So I think, just to echo the comments I made earlier, I do find that actuaries tend to have really well-defined roles in the insurance space. But in the public health setting, I think there's a growing awareness of actuaries and a growing awareness of their capabilities, but it's still growing. And in a way that's really exciting because there's so much possibility, there's so much opportunity to apply yourself in a public health setting, and the role is really yours to define.
How exciting. And it sounds like we're well equipped to make a difference and to have an interesting career in public health.
Absolutely.
Yeah, wonderful. Anna, thank you so much for sharing your insight with us and also your tips about how people can, or how actuaries can make a step into public health and use their skills there. It's really exciting to see actuaries working for state government health departments and using those skills to help solve some of those really tricky problems. And especially as we've got more and more data, and that's linking across agencies as well. There's so much work to be done by people who have not only the analytical skills to manage that data and to analyse it, but also to understand the context and some of those broader things that you were talking about, some of those system-wide challenges. So thank you so much for sharing your insights with us today.
Thank you so much, Julia.
Thanks, Anna.
Right.